Beyond the Paper Gown inspires, informs, and empowers women with the latest information about our health and healthcare choices. Join in for provocative conversations with scientists, clinicians, policymakers, and innovators. Beyond the Paper Gown is hosted by Dr. Lyndsey Harper, internal medicine specialist and women's health advocate. The following information is for entertainment, educational, and informational purposes only. This information is not intended as a substitute for professional therapy or medical advice, diagnosis, or treatment.
Welcome to Beyond the Paper Gown. I'm Dr. Lyndsey Harper. Before we get started today, I'd like to tell you about another show in the Off-Script Network, The Heart of Healthcare. As you know, here at Beyond the Paper Gown, we try to look at all the factors that impact on women's health. The Heart of Healthcare likewise expands the traditional lens of what we think of as healthcare by exploring the social determinants of health, including our food system, housing, climate change, and more. Quite simply, this is a podcast about improving the health and well-being of everyday Americans. You'll hear from the people behind the movements to better understand the underlying problems and how we can work together to solve them, such as Mark Cuban talking about his new company focused on reducing drug cost, or a physician warning us that we may not have enough primary care providers. Of course, one of my favorite episodes makes the point that women's health is not a niche. If this sounds good to you, as I know it does, please find the link in our show notes. Today's topic is sexual health. So, fair warning, we are going to have a very candid conversation about this very intimate subject. Our guest is Dr. Lyndsey Harper. She is a practicing ob-gyn, as well as sexual health specialist, and the CEO of Rosy Wellness. Welcome, Lyndsey.
Thank you so much for having me. I'm thrilled to be here and get to talk about my favorite topics.
Terrific. Well, we're glad to have you. And, this is a difficult topic to talk about, I'm sure, for some people, or maybe even most people. So I'm just going to jump in. And how do you start a conversation with your patients about sexual health or sexual wellness?
The way that I like to teach other physicians how to do this and to talk to patients about it is really by opening the door and saying, really women's sexual health problems are actually very common and are experienced by 43% of women. Right. So that takes away whatever shame or stigma or embarrassment we might as individuals be feeling, because since there is so much lack of conversation in society about these topics, oftentimes women feel like they're the only ones suffering with these problems. But in fact, they're very, very common. So I start by saying, lots of women have trouble with these issues. And I know that they can be disruptive in your life, because I think when you hear your physician acknowledging that, a women's sexual health issue is not something to be dismissed, but something to be actually taken seriously, that gives the patient the permission and the room she needs to potentially disclose whatever problem she's having. And then I say, do you have any sexual health or sexual function concerns that you would like to share with me today? And that gives them the opportunity to say, okay, these are really common. My doctor understands that they can cause, serious ramifications in my life. And she's inviting me to then have a confidential, discussion that's respectful. And I think that when we convey those values and those intentions with our patients, that hopefully they feel more comfortable talking to us about it. If not, that's okay, because then they know when they go home over the next year or 6 months or 1 month until you see them the next time, that if a sexual concern or issue comes up, that they have a safe place to go and discuss those things. So even if you don't have an issue going on at the time, the patient now knows that, there's an open door for future conversations.
And so let's turn the table and say that a physician isn't asking those questions that we would like them to, and a woman does have a problem. How should they initiate the conversation? Because I think that most women would say, well, if they're not asking, they really don't want to know. Don't ask, don't tell. There may be physicians who feel like it would be prying, or that the woman might be offended, or something like that. So how would you suggest that they initiate that conversation?
The challenge with sexuality, sexual health is that because it's been absent from our conversations for so long, it's hard for any of us to talk about, physicians, patients, and it's very emotionally charged. Oftentimes we might feel guilt, or we might feel shame, or we might feel embarrassment. And those feelings that are on top of the actual medical problem can really hamper the ability to get to what the problem is. But if we can say, okay, I've had sexual pain since the very first time I was ever sexually active. It's, this makes it worse. This makes it better. These are the things I've tried. Then those really important facts can help that physician kind of get to an answer faster. But it may be the case that they are not sure what to do. And then in that situation, I would say that what we need there is just a respectful conversation with a request for a potential referral. So just like you were mentioning, if your physician doesn't know what to do with a specific complaint that you're having, it's on us. It's our sort of next obligation to get you to someone who really does know those things. And increasingly so, there are more and more resources in the field of women's sexual health. That wasn't true a few years ago, but we're getting some more really knowledgeable people in the field.
Let's go ahead and just dive into some of the challenges that you see commonly for women, especially women that may be entering perimenopause or menopause.
Absolutely. So when we think about sexual dysfunction, there are really several domains in which we sort of place patients. So the first is low sexual desire. So many would say low or absent sexual desire. And, it's important to qualify here that if you identify as an asexual person, meaning someone who has never been interested in sex, someone who that is not, something that would ever sound like an interesting idea to you, that is different, right? Low sexual desire specifically is I had what I thought at one time was to be an acceptable level of sexual desire, and that has changed for whatever reason. And that happens so frequently, right, to women, not only perimenopausal, but a lot of times even earlier, just because of our multiple, responsibilities that we have going on in life, lots of life stressors, the longer a relationship goes on, all of these factors can kind of play into that. So low sexual desire is the most common one, reported by about 38% of women, and distressing low desire, meaning there's some sort of life problem caused by that, whether it's your own self-esteem, whether it's your relationship, whether it's affecting your levels of anxiety or depression, that low desire plus distress is experienced by about 10% of women. So that's a very big number of women, especially for us to not know, exactly what to do for these patients. The second most common issue is trouble with arousal. So we talk about desire being in the brain. So those are chemical reactions happening in the brain that are thoughts of us wanting to initiate sexual activity, whether with ourselves or with a partner. And arousal actually happens in the body. So arousal is like an erection in men. The same things happen in the clitoris and in the vulva. It becomes engorged with blood and enlarges in size. Often this is associated with throbbing or pulsating in the pelvis. So desire is the most common problem that women face, but arousal, actual trouble with physical arousal, much like men have trouble with arousal with erectile dysfunction, is the second most common. And that's experienced by about a quarter of women. So once again, a super common problem, many causes, but some of them are the same as in men. So, heart conditions, diabetes, certain medications. When we think about the reasons that they happen in men, they often happen for the same exact reasons in women. And then we can add in some, nerve or blood vessel injury from childbirth or surgery or any other trauma to the pelvis. The third most common issue is actually sexual pain, and that's experienced by 10 to 20% of women, and that's chronic sexual pain. Most of us will have sexual pain at some point in our lives, whether it's after a baby or, something temporary due to ovulation or something like that. But this is chronic sexual pain, meaning pain happens with sex most of the time. And obviously that's extremely distressing. And has a lot of potential causes, including endometriosis, scarring, changes in hormones that often happen with perimenopause or menopause. When that estrogen starts to decline, the vaginal tissues really start to become more thin, they become less lubricated, more prone to infection. So that can become a big issue around and after menopause. Next, we have trouble with orgasm, experienced by also about 20% of women. Same factors for risk for that as for arousal. And then Lastly, we have trouble with lubrication. Once again, could be a hormonal problem, usually experienced after babies, during lactation, or around or after the time of menopause.
You mentioned lubrication, and so that leads me to think about, not only after childbirth, but again, um, uh, getting into perimenopause and menopause. There's so many things, though. Estrogen changes can also lead to hot flashes, mood swings, um, uh, sleep problems. I'm assuming all of that takes a real toll on women's sex lives.
Absolutely. And how could it not? And what part of life does it not take a toll on? So it's just another
That's true.
just another example of why it's so important to treat these menopausal symptoms for women, right? We pretend that it's a normal part of life and it's not a big deal and we should all kind of like work through it or struggle through it, but the fact of the matter is it has a huge effect on our own personal sense of self, on our, level of productivity and engagement at work, on our, level of anxiety and interactiveness with our family, and certainly on our sex lives. Stress is the number one desire, killer. And I can't imagine a more stressful time than menopause, right? It's stressful for so many reasons. And so the sooner we can alleviate those symptoms for women effectively, the better, or the sooner we can also alleviate the fallout from those symptoms, including sexual side effects.
I also think about women who may be newly divorced or, having been in a monogamous relationship and now going out and dating. And what do you talk to them about?
My favorite sex therapist with whom I gave this ACOG talk, named Lori Mintz, she often refers to a sexual script, right? So in a long-term relationship, often we develop these sexual scripts where we're like, okay, this is what our sex life looks like. This is what we do. This is what we don't do. And this is how we interact with ourselves and our partner. But whenever we're, coming out of a long-term relationship and entering, a new phase of life, it's an opportunity to rewrite that sexual script for ourselves. And what that requires is that we take a look at what it is that we as individuals actually want. And I think that that's a huge thing that happens after the end of a long-term relationship, and can lead to a lot of future fulfillment, because sometimes our wants and needs maybe have, been morphed by our partner or for our partner. And so it's a time where we can rediscover what's important to us again. And oftentimes later in life, we're able to say that with more confidence. We're able to, to identify those things with more conviction. And it really just requires some self-examination, just like everything else, when there's a big major life change, to say, hey, what am I into? What am I not into? What do I want to try? There's so many opportunities, and it's never too late to reimagine, what that part of our lives can look like, for sure.
Sure. And unfortunately, we're never too old to also be exposed to new sexually transmitted infections.
Yeah.
So I would just,
That's true.
I'm sure you also tell folks to still use, if they haven't been using protection, because we're used to using protection for contraception. And maybe that's no longer an issue, but certainly you still need to use protection.
Absolutely. Yes. And at any point in life, if you're having unprotected sex with, with a non-monogamous partner or multiple partners, definitely we're at risk for all the STIs. And, that's just a bummer. That just leads to a lot of other issues that we don't want to
Yes.
deal with. So we might as well express our sexual freedom by also protecting ourselves from these things that can kind of get in the way of that as well.
And you talk about what sex means to individuals, whether it comes from their sexual orientation or gender. And it dawns on me that there are a lot of cultural norms that have to also be addressed and maybe sometimes transcended. And so can you speak a little bit about that?
Yeah, I think I am in Texas, so we have a lot of cultural norms down here. But what's fascinating to me is that this exists all over the world. And so I think what's the most helpful tactic that I have employed is to really meet women where they are and to really understand what's important to them and how we can help them through their current context to live the most sexually fulfilled and sexually healthy life that there is, right? Whether that is offering them permission to have a conversation about sexual problems, or it's, really guiding them through with a therapist or with a sex therapist to release whatever shame or guilt they're holding on to from something in their past, or, even exploring through their own personal religious text. And this isn't something that I do because I'm not involved deeply in any of these religious communities, but we have been able to identify, people who are not only sexuality experts or sex medicine doctors, but who also are devout women in their faith. And those women are really able to talk to, these patients based on, their religious texts and say, within marriage, this is how sexuality was written about in these religious texts. And you'll find there's such a commonality between all of them, which is fascinating, which is that within the context of their religion, within the context of their relationship, that, whomever the higher being is in that context means for that to be a fulfilling relationship. And so then we do whatever we can to support the woman on that journey and to reassure her that her sexuality is not bad, her sexuality is not dirty. And there's so many opportunities to really live a fulfilling aspect, a fulfilling sexual life within those contexts. So it can be really beautiful. It feels complicated, but it's actually not, because it's the same sort of stories repeated, but throughout different cultures and religions.
Let's talk a little bit about some of the more common issues that you're seeing and maybe some of the treatments or referrals that you make.
Yeah, great. So as we mentioned, low desire or decreased libido is the most common sexual complaint that women have. And there's actually lots of interventions that are evidence-based. And whenever we think about a sexual problem, we really think about it in three different parts. The first is the biology, right? What's going on in the body that could be contributing to this. The second is what's going on from the psychology side of things. That includes those cultural sort of overtones or undertones that we were talking about. That includes any anxiety, depression. That includes body image issues. All of those things fall under the psychological component. And then the last is the social component, right? What's going on in the relationship? What are the other extraneous factors that can really be affecting this clinical picture? When we think about it from the most common issues are the most common causes, and that's really going to be stress, which we discussed, and that can actually be effectively treated with mindfulness tools, which I know everyone's like eye rolling about mindfulness these days, but they're actually so important, right? When we are feeling stressed, that we're not going to allow room in our brain for sexual thoughts. When we're feeling stressed and our partner, touches us in a way that might be intimate or sexual, we are not going to receive that in the way that they intend it, right? We're going to instead tell them to please get away from us, or maybe not so nicely. And so we really have to work on our own sense of stress and anxiety in our life, because that can take a really big toll. And so obviously that can be done through mindfulness. That can also be, if you have a clinical diagnosis, then obviously there's always ways to decrease anxiety and stress as well through medication.
When we return, Dr. Harper provides a surprising prescription for improving low sexual desire. When asked about common issues she sees in the office, Dr. Harper told us that low sexual desire is one of the most common complaints she encounters. In addition to reducing stress and anxiety, she frequently makes another recommendation.
The other really interesting evidence-based intervention that's non-pharmacologic or you're not taking a pharmaceutical for is erotica. And this one, everyone's always like, erotica, like, what are you talking about? But this is actually really, really helpful. So there's an idea of spontaneous desire and responsive desire. And I love to explain this basic understanding to patients. So spontaneous desire is when the idea or the desire for sex comes into your brain from nowhere, just from the heavens above. And you're like, oh, I would love, to have a sexual encounter. That sounds great. And when we're younger, that sometimes women identify with that. But over time, as we age, sometimes women will stay on that track, but oftentimes this idea of responsive desire actually starts to become more prominent, which is that when we encounter a sexual cue, for example, erotica, then that becomes that shows up as arousal in our bodies. So we talked about that engorgement in the genitals, the pulsating, the throbbing, and then that actually sends the message to our brain that, hey, actually a sexual encounter does sound pretty good, right? So that is a different way of thinking of things that women can tap into if they think they have low desire. Many times they actually have, in fact, responsive desire, where when they access something like erotica, if their goal is to increase intimacy, then they can, in fact, increase desire for intimacy through one of those pathways. So erotica is a great tool. Also, exercise has been shown to improve sexual desire. So 20 minutes of vigorous exercise 3 times a week. And it's, in fact, right before. So like exercise, shower, no shower, and then sex. Because what happens is it increases blood flow, and it also boosts your mood, right? So these other things that we're talking about really can come into play, and be expressed through that other behavioral intervention. There's some other opportunities in terms of changing our thought patterns around sex and around desire, and sort of what are the benefits of it. And then lastly, there are pharmacologic agents for something called HSDD, or hypoactive sexual desire disorder. And that describes women that don't have spontaneous desire, nor do they have responsive desire. So, the way that I can explain this to patients is that they could be on a desert island with the partner of their dreams in the sexiest environment, least stressful environment ever. And they still are like, no, thank you. Like, this is not for me. I don't want to do this. And so that could be diagnosed as HSDD in certain circumstances. There's some other qualifiers. And there are 2 pharmacologic interventions for that. The last thing that people often ask me about is testosterone, because that comes up all the time. And it is not FDA approved for any sexual complaint in women, or actually for anything in women, but we know that it does work. The challenge is we don't have great long-term data. So ACOG supports use for up to 6 months. The challenge is getting it paid for, following it. So it's something that sex medicine doctors use frequently, but it's not approachable for many OBGYNs or internists because they're just not quite sure how to dose it, and they're concerned about that lack of FDA approval.
And what about the adverse effects?
Yeah, so the challenge is we don't have any long-term randomized controlled trials to talk about the adverse effects. If women are dosed above the range where they should be, we can oftentimes see abnormal bleeding from the uterine lining. We can see, lowering of the voice. We can see abnormal hair growth. We can see the clitoris enlarging in size. So those are not common. And if you are dosing in the right way, meaning you are following levels, then those things should not happen. And our preferred dosing of testosterone is transdermal, meaning like a cream, and not in a way that cannot be removed like a pellet. That is not a good idea.
You mentioned mood and stress, but also potentially the effect of depression and anxiety. And there's so many women that are on selective serotonin reuptake inhibitors, otherwise known as SSRIs, like Zoloft, Prozac, and so forth. And those, as a side effect, have reduced libido or reduced, I shouldn't say, I don't know if it's reduced libido or reduced orgasm, ability to orgasm. You can clarify that. Yes. And so how do you treat that?
Yeah, that's such a good question. So yes, most of the older SSRIs that we prescribe frequently, because they're well covered by insurance, patients can get their hands on them easily, do have, sexual side effects. And that can show up as lower desire, that can show up as decreased arousal, that can definitely show up as absent or inhibited or delayed orgasm. So this is something really that I feel like we should all be counseling patients on when we start them on these meds, because when we start a man on a beta blocker, we're certainly telling him that it might affect his erection. And he already knows that because it's all over the place. But women don't know this about the medicines that we prescribe for them. So we owe them that. The other thing that's really important for patients to know is that depression and sexual dysfunction are often comorbid, and that's okay. They run together. And so what that means is that we are oftentimes explaining to patients that those patients who are depressed and have sexual dysfunction actually, and who are treated for their depression, do better than patients who are depressed and who are not treated for their depression. So we don't want to recommend that everyone stops their SSRIs. We don't want to recommend that, we're just throwing throwing our depression and anxiety medicine away, because we really do have to treat those mood symptoms. It's just that we want to do so in a way that's respectful to, sexual side effects as well. So it's sometimes takes a couple of tries, but it can be possible. And sometimes you got to bring in somebody, who knows a little bit more about these things.
Thank you. One other topic I just wanted to touch on is that how do you approach the woman who's had a history of sexual trauma?
Yeah. It's interesting. Sexual trauma, first and foremost, is so common, sadly, right? There's so many women who are dealing with this. And many women don't ever talk about it, not one time. And so we, as clinicians, as physicians, we should always just be aware of how common these things are, and that sexual trauma does not always mean sexual dysfunction. I don't think it's helpful for us to say, oh, this patient has XYZ. She definitely must have had some sexual trauma. Like it's not helpful to equate the two, but it's always helpful to understand and be aware that any person, male or female, when we're speaking on this issue, particularly our women patients, could potentially have been a victim of, sexual harassment, sexual trauma, sexual violence, however we want to talk about it and define it. And to just understand that even if it wasn't something that, would be prosecutable by law, it's really not even about that. It's about the person's lived experience of it. It's about how that affects their current context now, and just to be super respectful of that. My go-to, if someone feels like there's an opportunity to work through a sexual trauma or sexual violence, is to send them to therapy. That's not something that I am trained to do or equipped to do, but I am trained to be aware, and I am trained to be sensitive, and I am trained to let the patient guide the conversation and the exam in a way that feels really comfortable and approachable to her. And I think that we can all do that for our patients, even if we're not trained, to help patients through a sexual trauma.
So let's move on to, I think the issue of vaginal dryness and what your recommendations are. And I want to specifically not only talk about lubrications and moisturizers and all of that, which is obviously very important, but let's also talk about estrogen and the different ways that one can use estrogen.
Sure. So when it comes to vaginal dryness, there's, the most common cause of vaginal dryness is lack of estrogen, right? And so we can overcome lack of estrogen in many ways. And lack of estrogen can happen for lots of reasons. As we mentioned, it can happen from lactation, if you're making, milk to feed a baby. It can happen during perimenopause when the hormones are fluctuating. It can happen postmenopausally. And it can happen as a result of like a surgical menopause where the ovaries have been removed, or a chemical menopause where a patient is taking a hormone receptor blocker for a cancer diagnosis or some other diagnosis. So those are the most frequent use cases where people are experiencing lower levels of estrogen, which lead to vaginal dryness. As we mentioned, the ramifications of that are usually sexual pain. Also, that the skin is just thinner. So there's no lubrication and that skin tears more easily, which increases the risk of infection, both vaginally and of the urinary tract, right? So UTIs. So none of that is fun. None of that is good for sex. And there are lots of different ways we can think about approaching it, right? So, I think all people should use lube all the time. There's nothing wrong with lube. Lube doesn't mean that you've got a problem or you're not turned on, or you don't like your partner or find them attractive. Lube, there's actually data to show that lube increases pleasure for all couples that that use it. So there's no reason we shouldn't all be using lube in the first place, but particularly for people with vaginal dryness, it's a great first place to start. And there's lots of different types of lube. There's water-based, there's oil-based, there's silicone-based. My personal favorite is silicone-based. But there are a few caveats, which is that if you use them with silicone toys, then they can break down the silicone. If you're cleaning your toys properly, that's probably not as much of an issue. So then after we talk about sort of the over-the-counter lubricants that are available, then we move into the pharmaceutical agents. And as you alluded to, there's lots of different preparations, right? So we can start with the estrogen ones. There's estrogen cream, there's estrogen tablets, there's an estrogen ring. There are also other types of estrogen that are meant more for systemic symptoms. So there's estrogen tablets you can take by mouth. There's also an estrogen patch, an estrogen like gel that you can kind of rub in. Those actually work throughout the body, including the brain, to really work more on hot flashes, mood changes, sleep, all of those things. If we're talking specifically about vaginal dryness, the hormones that work best for those are the ones that go in or on the vagina, right? Or really in the vagina is probably the way I should say that most correctly. And sometimes women are on both, and that's totally fine. You can take oral estrogen or estrogen via a patch and also use vaginal estrogen if you need it. The other option that I actually love for trouble with decreased estrogen or atrophy, or there's lots of names we could call this, is prasterone, which is vaginal DHEA. And the reason that I love it is because the body converts the DHEA into estrogen and testosterone. So you get the local effects of both of those hormones on the vulva and the vagina. And there are testosterone receptors in the vulva. So there is some data to suggest that vaginal prasterone or DHEA has a more beneficial side effect profile when it comes to sexual function benefits. So if it's a patient that I'm treating for sexual dysfunction and lack of estrogen or atrophy in the vagina, then I will usually reach for prasterone. And there's no black box on that for, cancer patients and things like that.
All right. And can you explain what black box is to our listeners?
Sure. Yeah. So black box, whether we agree with this black box or not is a different story, but means that there's a recommendation from the FDA that you don't use a medication in a certain population. And for estrogen, because of this WHI trial that came out a long time ago and now, many, many years later has been sort of questioned upside down and all around, the black box remains on vaginal estrogen. To say that patients who have been treated for hormone receptor positive breast cancer should not use it. Many, many people disagree with that, myself included. Women who have breast cancer are suffering in a big way with sexual side effects after their cancer diagnosis and from all the medicines that they're taking. And they deserve to make an informed decision. And most of us know that these vaginal preparations are not absorbed systemically. And it should be the patient's decision whether or not she wants to use these vaginal hormonal preparations to sacrifice, to revive her sex life and sexual function rather than living for however many decades more, with no sexual function intact.
And just to underline what you just said, and please correct me if I'm wrong, what you were alluding to is the Women's Health Initiative, which was a large study that really focused on estrogen, or what we think of as hormone replacement therapy. And there were some initial results that suggested that the risk of breast cancer would be increased, but they really kind of made a blanket statement when in fact there were a lot of nuances. And so that's what you're alluding to, correct?
Absolutely, yes. And the way that estrogen was prescribed in that study is not the way that we use estrogen, in regular practice for patients who are menopausal with symptoms. And there's a lot of opportunity for improvement on that data for sure.
Sure. And to your point also, if someone, usually when we prescribe what again would be considered hormone replacement therapy with an estrogen pill, for example, if someone had a uterus, we prescribe progesterone so that the risk of endometrial cancer is reduced. Do you need to do that with vaginal estrogen?
Such a good question. You do not need to do that with vaginal estrogen. It is not necessary with vaginal estrogen preparations. Okay. But yes, if you're taking estrogen orally or through a patch or a cream, then you do need progesterone if you have a uterus in order to protect against endometrial cancer. Absolutely.
Want to go to what you were talking about in terms of potential alternatives to estrogen if somebody decides that they don't want to use that. And one of those is a device that can increase blood flow to the vagina and reproductive organs. What do you think about those kinds of opportunities or options?
Yeah, they do have some data to show that the laser type therapies that you're talking about can be beneficial postmenopausally. It's not first line, right? It's not what we reach for first and foremost. But like you said, if a patient for whatever reason does not want to do hormonal therapy, then that's something that they can consider or can consider it as an adjunct, meaning in addition to. So I think that there's a lot of opportunity for future knowledge and research in those studies, including for breast cancer patients. We know that, patients who have had cancer, or who specifically who are on aromatase inhibitors, like a lot of breast cancer patients are, that those lasers can work differently in those patients. So we're still kind of awaiting that data to say, across the board, that that's a great intervention for these patients. We know from a cellular level that there should be benefit, but sometimes, that cellular makeup can be changed with some of those other medicines that breast cancer patients are taking. But those trials are going on right now.
A couple of potentially random questions, and then we'll wrap up a little bit. I'm interested in the role of masturbation in sexual health, and if that's something that you suggest to your patients.
Oh, such a good question. Yeah, I call it self-pleasure, because masturbation can be a little bit daunting for patients and doctors both. I think that that's like a hard word to try to get people to say. And really, when we back up, when we think about it, there's a lot of value to it. And I talk about it all the time. And the reason is because there's many reasons, but the primary ones are because, number one, if we are feeling too anxious or nervous or ashamed of our bodies to even kind of figure out what's going on down there for ourselves, the likelihood that we're going to be able to enter into some highly communicative, highly pleasurable sexual relationship with someone else is pretty low, because those same feelings are going to be kind of getting in the way, right? And so it's much easier to work through some of that stuff individually than it is to introduce another person who probably has their own stuff to work through. And then we're all trying to work through our stuff together while also not ever talking about it. It's just a little confusing how all that's going to work out. So for that reason, I think it's really important. And the other reason is just really like logistics, right? Like if we don't know what feels good to our own body and our own selves at certain, phases of life, then how will we ever be able to share that or communicate that to someone else? And so there's really like a guilt, shame, pleasure factor, and then there's a logistics factor, both of which are super duper important. And, there's also a third component, which is just a health factor. It's very rare, and maybe even never in a relationship, did two people want to have sex with one another always at the same time, right? Like that's just not a thing that actually happens in real life. And there shouldn't be any, issue with, okay, as long as we're communicating about our sex life together, I think that there's not any reason why people shouldn't also feel comfortable with self-pleasure or masturbation in conjunction with that, a coupled sexual relationship. So there's many health benefits to orgasm. We could talk about all of those. We could talk about, so many opportunities for anxiety and stress relief. So I think that when you think about it in that way, that there's lots of reasons to encourage that, for women, for patients, and sort of normalize that experience.
You actually anticipated my next question is, what are the health benefits of sex?
Yeah. Oh, there's so many. So there's amazing things that happen in our body, right? Whenever, even before orgasm, even just with touch of our own bodies, right? So being present in our own body, being present with a partner, really focusing on that mindfulness or being present in our bodies. And there we get tons of neurotransmitter release in our brains. We get tons of hormone release in our body. And these can decrease stress, decrease that cortisol hormone, and increase all of our feel-good hormones, including oxytocin, including serotonin and norepinephrine. When we have functional MRI scans of the brain at the time of orgasm, which shows the same exact brain state as like complete mindfulness, which results in tons of cardiovascular benefits, and also, as I mentioned, those longer term stress and sleep benefits too as well. So lots of reasons. I think it's an understudied field that we, have yet to really explore. But we definitely have some great early indicators and early reasons. And we as humans know, right, that it's good for us because it feels good. We want to engage sexually, at least at some times in our life. And so there's that knowledge that it's there. And there's so many more opportunities for research as well.
I think that we all feel like as we age, it shouldn't be as important, and that maybe we have a reduced expectation that we're going to have a pleasurable sex life. What's your thought on that?
Oh, it makes me sad. I don't want anybody to feel that way. I think that as we age, we, become more liberated in so many parts of our lives. We feel free to say what we think, I also think we should feel free to express ourselves sexually. I think there's some, really exciting things that happen with aging in terms of confidence, in terms of potential connection and permission with your partner. And it's, I really view it as an opportunity to continue that, that sexual journey, which we alluded to earlier. So I don't think there's any point in life where sexuality should be over. There's times where our bodies don't want to cooperate with, our desires or our hopes. And in those cases, it can be worked around, just as we discussed, rewriting the sexual script in cases of, erectile dysfunction, or if people have had, some sort of issue where they're not able to have penetrative sex, that's fine. Let's rewrite that script. Let's look at this, in as many other ways as are offered to us, and really continue that connection with our sexual selves and our relationship with our partners.
Thank you. So what did I not ask you or cover that you think is important?
Well, I just would love to emphasize how common sexual concerns are, and that not only are they common, but there are really great evidence-based things that we can do to help women with sexual concerns. So if you are experiencing something, or your best friend or your mom or your daughter or, your sister, the most important thing that we can all do is to start talking about this more openly, right? And in a way that really focuses on sexual health as part of our health. Not in a way that's, dismissive, not in a way that's like joking, but in a way to say, hey, we as women deserve more. Like this is part of our lives that we deserve to really understand, to really, take advantage of. And there's no reason, I don't want anyone to be suffering in shame or embarrassment.
Absolutely. And I'm sure it's related. What would be your call to action for anyone listening? What's one thing that you would ask them to consider doing?
Oh, there's so many things. I think it would be to maybe seek out some sort of evidence-based resource for sexual health, whether it's a book, whether it's your healthcare provider, whether it's someone who's really knowledgeable in this area, because the power that knowledge has in this area is huge. If we could erase the shame and isolation and lack of evidence-based education that, is pervasive across the world, we would solve more than half of women's sexual health problems. So it's really spreading that, evidence-based information and sharing that with others around us. So that's what I would challenge everyone to do.
And we'll again add some resources that you'll help us with in our podcast notes. So thank you for that.
Great.
Dr. Lyndsey Harper, thank you so much for coming today. It was really a pleasure.
Well, thanks for having me. I love talking about this stuff, and I appreciate the opportunity.
I hope you enjoyed this episode. I know I learned a lot. Here are some takeaways and some editorial comment from me as well. First of all, sexual concerns are common in women. In fact, 43% of women report having difficulty with some aspect of their sexual lives. Your physician is a good place to start, and even if they don't bring it up, you should. While you can talk about this at your annual visit, you can also make a specific appointment to just address your concern. In fact, if you are having a problem that's new, it's important to check it out as soon as possible. There may be an underlying medical issue that needs attention. Of course, not all doctors are trained or comfortable talking about sexual health beyond ruling out a medical condition. In that instance, you could ask for a referral or consult the resources in our podcast notes. We can sort sexual problems into the following categories: desire, arousal, pain, orgasm, and lubrication. 38% of women complain of a change in sexual desire, which can have multiple causes, such as stress or hormonal changes. You can think of desire as a mind issue and arousal as a body issue. Just like erectile dysfunction in men, women's arousal may be hampered by medical conditions such as diabetes, vascular disease, or injury to blood vessels and nerves. Some medications can interfere with arousal as well. 10 to 20% of women complain of chronic sexual pain, which can be caused by disorders such as endometriosis. But if something is new, that too needs to be checked out by a physician to rule out a possible medical condition. Orgasm and challenges with lubrication can be both mind and body issues and are very common in women as well. Treatment for these various issues depends on the cause. Options include stress reduction and therapy for relationship and anxiety issues. Erotica and exercise can also help increase desire. There are medications for certain types of diminished sexual arousal. We also discussed the use of SSRI antidepressants. Some can have a significant effect on desire, sexual arousal, and orgasm, as can depression itself, so sometimes it's a trade-off with respect to treatment. It's important, though, to discuss these sexual side effects with your doctor. Sometimes changing medication can help solve the problem. Women with a history of sexual trauma can also face challenges when it comes to sexual health, and talking with a professional can help. However, as Dr. Harper notes, sexual trauma does not necessarily lead to sexual dysfunction and should not be the only factor considered if there is a problem. Vaginal dryness can occur in lactating moms, women undergoing chemotherapy, and women in menopause. It's a common problem. Treatment options can include lubricants, estrogen, and other topical hormones, depending on your medical history. So you may wonder, why spend so much time on this issue? Because sex can be good for you. Some benefits include releasing lots of feel-good, stress-releasing neurotransmitters, improving sleep, and even helping heart health, as well as enhancing your relationship. And you don't have to be young to reap those benefits. In fact, age has its privileges, like feeling more confident and being able to decide to rewrite your sexual script. I hope this episode has empowered you to take charge of your sexual health, and if you are having difficulty, to seek help from a physician or other skilled provider. If there's something that works for you, we'd love to hear about it on our community forum at beyondthepapergown.com. I'd also like to invite you to rate us on the podcast platform you subscribe to. That helps to tell them that you like this podcast and makes it more visible to others as well. I'm trying to get just 5 new ratings. I hope you'll be one of them. I really appreciate it.
I do hope you'll join us if you enjoyed today's episode. Please subscribe. For more information on this episode, or for additional episodes, links, and comments, find us at beyondthepapergown.com or follow us on YouTube, Instagram, Twitter, and Facebook. This episode of Beyond the Paper Gown was produced by Patrick Shambayati and Dr. Lyndsey Harper. Until next time, stay healthy and centered.